Hello, this is the emergency tutorial for on acute pulmonary edema presented by the SchrDbb with reference High School Internal Medicine by Dennis Kasper ER. So acute pulmonary edema. So what is acute pulmonary edema? It's a life-threatening acute development of alveolar lung edema. So pulmonary edema is just alveolar lung edema. We have now characteristic of this edema is going to be having one, hydrostatic pressure in the pulmonary capillary is going to be increased. Are you getting? Hydrostatic pressure in the pulmonary capillary is going to be increased. One, you have two, specific precipitant resulting in cardiogenic pulmonary edema in patients with previously compensated heart failure. So you are going to have also precipitating factors are also associated with pulmonary edema in patients that had initially a compensated heart failure. And three, you have increased permeability of the alveolar capillary membranes can also be associated with that in case of a non-cardiogenic pulmonary edema. So those are the three main characteristics. Pulmonary edema major characteristics, you have an increase in pulmonary capillary pressure. Number two, it can be due to pulmonary edema can be due to the heart, and when you have a heart problem, you must have a precipitating factor such that you have the pulmonary edema, and also it may be due to increased permeability of the pulmonary alveolar capillary membrane in case of a non-cardiac pulmonary edema. So what are the physical signs of pulmonary edema? One, the patient generally looks ill, severely ill. The patient looks diaphoretic, it means that it looks sweating, sitting bold and upright. So that's the general examination. General examination of the patient. He looks ill, he's sweating, and then he's bold, sitting upright. So that's pulmonary edema. Then the next one is tachypneic. So he's tachypneic, he has cyanosis and may be present. Bilateral pulmonary arrest, you have third heart sound may be present, and bilateral pulmonary radius. So it means that you have crackles bilaterally. You may have third heart sound in case of a cardiogenic pulmonary edema. You're having a third heart sound, and a third heart sound is produced when when blood coming from the artery is meeting leftover blood from when blood coming from the artery is meeting leftover blood in the ventricle. So we have now frothy, we have blood tinged sputum may occur. The next thing is a laboratory investigation. So when you have acute pulmonary edema, what laboratory investigation do you do? As you have to do pulmonary function tests. The pulmonary function test must first include here the arterial blood gases. So the arterial blood pressure, you have partial pressure of oxygen, partial pressure of carbon dioxide. Then the next thing you do is you have to do imaging of the lungs. You visualize for a chest X-ray for pulmonary vascular redistribution in cases of a heart failure. You have a diffuse haziness in the lung field and the perihelia. That's butterfly appearance. So you may see also a butterfly appearance. Acute pulmonary edema, immediate aggressive therapy is mandatory to survival. The following measures should be instituted as simultaneously as possible for cardiogenic pulmonary edema. We have now the precipitating factors. What are the precipitants of acute pulmonary edema? So the precipitating factor of acute pulmonary edema can either be one, anything that can increase the contraction of the heart rate. That's the first thing. Number two, anything that increase the afterload. Number three, anything that increase the preload. And number four, anything is related to the patient. Now, anything that increase the heart activity, we have tachycardia. In tachycardia, in case of an infection with fever, is going to increase heart activity. If you have hypoxia, it's going to increase heart activity. If you have hypovolemia, you're going to increase heart activity. So if you have also pregnancy, it's going to increase heart activity. So those are the cases. Or if you have atrial fibrillation, it's also going to increase heart activity. Is it clear? Now the next thing is related to the heart. And related to the heart, you have myocardial infarction can precipitate the heart failure. Are you getting? Now, if you have a problem with the afterload may be on the pulmonary circulation, may be on the systemic circulation. Systemic circulation, if you have a patient that has severe hypertension, is going to result to it, if you have in the pulmonary circulation, if you have a patient with a pulmonary hypertension, it's going to result to heart failure, and if you have a patient with pulmonary embolism, it's going to result to heart failure. It's going to precipitate the heart failure. So the next one, if you have if you have the patient now, if in case of a increase in preload, you have increased circulating volume like sodium injection, blood transfusion, or pregnancy, you have increased the metabolic demands, like that's going to increase the heart rate, you have hyperthyroidism, you have exercise, and you have non-compliance with medication. So what are the common causes of non-cardiogenic pulmonary edema? Now, non-cardiogenic pulmonary edema can either be direct injury to the lungs, it can be from hematogenous injury to the lungs, and you have possible lung injury plus elevated hydrostatic pressure. Now, if you have direct injury to the lungs, it may be chest trauma that resulted to the non-cardiogenic pulmonary edema. It may be aspiration that results in non-cardiogenic pulmonary edema, smoking, pneumonia, oxygen toxicity, excess oxygen, and pulmonary embolism may result to it. Now, you have hematogenous injury to the lungs. So the hematogenous injury to the lungs can result to pulmonary edema. You have sepsis, you have pancreatitis, non-thoracic trauma, you have multiple transfusions may also result to a non-cardiogenic pulmonary edema. You have possible lung injury, you have high altitude pulmonary edema, and other. So now, how do you manage a patient with pulmonary edema? So in pulmonary edema, the emergency problem is that the patient has excessive fluid in the lungs, and then the patient lacks oxygen. So you have to administer 100% oxygen by face mask or by a nasal catheter. So I administer by a face mask or nasal catheter to achieve a partial pressure of oxygen of greater than 60 millimeters of mercury. That's the first point. If inadequate, use a positive pressure ventilation. So I can achieve by using pressure precision by a nasal mask or a face mask. If necessary, proceed to endotracheal. So if now the nasal mask does not work, you go down to endotracheal to intubation. So reduce the preload. The next thing is reduce the preload. Sit the patient upright to reduce the venous return, if not hypotensive. So you have to see the patient upright to reduce the venous return if the patient is not hypotensive, because if the patient is going to is hypotensive, blood is going to pool in the extremities. So you have to reduce the preload. So the question is, why do you reduce the preload? You reduce the preload to prevent excess fluid from going into the lungs, because the more the fluid is going to go to the lungs, the more there's going to be filtration, and there's more is going to be edema. So the patient should not lie. That's why this patient like the position of being sitting up in bold position. Are you getting? Because blood has to pull down to the extremities. Are you getting? Now the next one is intravenous loop diuretics. So you have to also reduce the preload by doing so. Generally, you just say the patient to stand to sit up, or he has also to stand. You have to do what? Intravenous loop diuretics like furosemide. So intravenous loop diuretics, use furosemide. You can use so these drugs. You have nitroglycerin, can also be used in vasodilation. So are you getting? You have morphine. So all these are going to be used in order to reduce the preload, because the main problem in this patient is that there is fluid accumulation, so you need to reduce the preload. So consider AC inhibitor if the patient is hypertensive in setting acute myocardial infarction and heart failure. So if you have to use the AC inhibitor, it's in order to prevent excess fluid into the systemic system, to prevent the systemic circulation from not having fluid and pumping the fluid inside the lungs. So you have to use also AC inhibitors. Nitroglycerin you have to use in order to prevent the afterload. It's not just to reduce the preload, but also to make sure that the afterload should be reduced, such that when the heart arrives into the lungs, it can easily penetrate the left heart. So if you have a high afterload, it's going to make sure that excess blood is going to still accumulate in the left heart and backflow into the lungs. So that's why you use AC inhibitor, you use nitroglycerin, which is a vasodilator. So now inotropic agents are indicated in cardiogenic pulmonary edema. Are you getting? Example, we have dopamine, dobutamine. So they can be used. So the Precipitating cause of cardiogenic pulmonary edema should be sought, because we have precipitating causes, as we have already seen above there. We have different precipitating causes of the cardiogenic pulmonary edema should be sought, particularly acute arrhythmia or infection. For refractory pulmonary edema as treated with persistent cardiac ischemia, early coronary revascularization may be life-saving. So now the next thing you're going to visualize now is acute respiratory distress syndrome.